Sir.
So we are hello.
Yes,
Hello.
Dhiraj. We can hear
Hello.
you.
Yes, we are live now.
Yes.
We are live now.
Yes,
Yeah,
yes.
yeah, Dhiraj, you're live.
Okay. So good evening, everyone. Good evening, all the respected faculties and esteemed panelists. So we welcome you all to the West Zone Orthopaedic Association Spine Ortho Seminar. And this is the third CME of its kind. And the theme this time is Thoracolumbar Fractures. And it is under the leadership of Dr. Ajit Shinde. Sir is the president of West Zone Orthopaedic Association. And sir is quite academically inclined. We have coordinators with us. I myself, then Dr. Agnivesh and Dr. Bhatia from Pune will be moderating. Apart from us, we have a huge esteemed panelist, Dr. Sanjay Dhar. We know the name throughout the country. Then Dr. Agnivesh, Dr. Deep Ghosh, and Pritam Majumdar. It's an honor for me to make Dr. Ajit Shinde to talk and welcome him as the president of West Zone Orthopaedic Association. Over to Ajit Shinde, sir. Please take over, sir.
Thank you, Dhiraj. Respected dignitaries of IOA and my team members of West Zone Indian Orthopaedic Association, Dr. Vikas Jain, Dr. Bandekar, Vice Presidents, and Secretary Dr. Naveen Thakkar, President Secretary of Maharashtra and Gujarat, Dr. Rajendra Abbenkar, Dr. Narayan Karne, Dr. Govind Purohit, and Dr. Kamlesh Devmarari, and all respected faculty members, good evening and welcome to webinar of West Zone of IOA. Friends, we have been discussing spine problems, and today we will be learning management of thoracolumbar injuries from the masters. We have eminent faculty with us. I welcome Dr. Pritam Majumdar, Dr. Agnivesh Tikoo, Dr. Sanjay Dhar, and Dr. Deep Ghosh. All are experienced stalwarts in this field. We have Dhiraj Sonawane, Dr. Shailesh Hadgaonkar, and Dr. Vishal Kundnani to moderate the session, who are masters in the field as well. Thoracolumbar fractures have wide spectrum of presentation and can occur as a result of high energy trauma in young adults or as a result of osteoporosis in elderly population. Patient may land up with debilitating pain or more devastating paraplegia. So it is essential to understand the basics of fracture and algorithm to manage the injuries. Finally, I thank Team Ortho TV, Dr. Ashok Sham and Dr. Neeraj Bijlani for their support. Now I hand over the further proceeding to our moderator, Dr. Dhiraj. Thank you for patience hearing.
Thank you very much, sir. So we'll proceed with the program. Dr. Tikoo has Agnivesh Tikoo is a spine consultant in Apollo Navi Mumbai. So he has already joined us and he will be taking over me. Dr. Agnivesh, you're joined?
Yes, Dr. Dhiraj, I'm here.
Yes. So Dr. Pallav Bhatia will be helping you as a moderator colleague. So you can hand over, you can take over from me right now. Yeah.
Thank you, Dr. Dhiraj. Thank you, Ajit Shinde, sir. And thank you, West Zone IOA, for giving us this opportunity to moderate this session. Without any further delay, I would like to invite the first talk, which is by Dr. Deep Ghosh. Dr. Deep Ghosh is consultant spine surgeon at Apollo Hospital, Guwahati, and has got vast experience in the field of spine surgery. His talk is going to be on classification of thoracolumbar fractures and how it evolved and what is the significance of the same. Dr. Jaideep, over to you.
Thank you, Dr. Tikoo. So I'll try my best. I work in Guwahati, and that's very opposite to from where you are. So, and I've been helped a lot by Dr. Tikoo in this making this presentation. Rather, most of the slides are from him. So basically, now let us go to the point. Why do we need a classification? We have classification everywhere in biology, in engineering, in physics. So basically, in case of fractures, we have to name a fracture. You know what a fracture is, so that you and me knows that it's the same fracture. To give a hierarchy, as per the like in AO classification of spinal fractures, the more the numbers A, B, C, the increasing grade of severity of the injury. And to guide management, because from the type of the fracture, what we have, we need a cookbook, a recipe for its management, and a management where most of the experts can agree upon. And we have to predict outcome, that you can say to the patient that, look, you will become okay by 1 month, or look, you won't be getting back any neurological benefit by this procedure. And we have to compare results among inside the center, among different centers, different countries, different settings, etc. So if you see the summary of classes, there are kind of 11 classes, and there are maybe more listed out. So if you jump from the timeline from 1 to 11, so this is the most old, this is the kind of most recent classification. So coming to Wohler classification in 1930, Wohler was a doctor in Vienna, Austria, and he used to pioneer the treatment of thoracolumbar fractures, and particularly with casting and very rigorous physiotherapy. So he divided these fractures into compression fractures, distraction, flexion distraction injuries, extension fractures with injury to the ligamentous fractures, anterior and posterior, shear fractures, and rotational injuries. At the time, the proper anatomy of the spine, this functional anatomy was not known, so this was what was done. Wohler was in 1930, that is post World War I, in the interlude between the World War I and World War II. And just before World War II, from UK, Dr. Watson Jones gave this classification. He introduced the instability concept and its effect on the treatment of thoracolumbar injuries as an addition to the Wohler's classification. So we now know that the integrity of the posterior ligamentous complex is essential for spinal stability, and it was not well known at the time, but it was alluded to that there is some structure in the posterior part which is essential for spinal stability. And he divided into 7 different types, 3 major patterns, that are simple wedge fractures, herniated fractures, and fracture dislocations. And stress to the facet joint because of severe wedging anteriorly, the radiological alignment is not improved. In 30 to 40% of these patients will develop moderate to severe pain. So it's like in tuberculosis of the child, like Dr. Rashikant gave spinal wrist size. So if you more wedging anteriorly, there's uncovering of the facets becomes now dysfunctional function in mechanical loading, and they go into progressive kyphosis and could lead to severe pain. So remember, this was a time when mostly conservative treatment was done. No operative treatment was commonly done at that time, and all the reduction used to be done. All the investigation was that X-rays, and reduction used to be done by close reduction, by posture, etc. And then fracture cast, the thoracolumbar cast used to be applied. So this was the time after World War II, and then in 1949, Nicol gave this classification. He studied 166 thoracolumbar fractures in coal miners. He gave He gave a morphological classification where there's anterior wedge fracture, there's lateral wedge fracture, there's fracture distribution, and neural arch fractures. He described the anatomical structures contributing to stability of the vertebral body, the disc, the intervertebral joints, and interspinous ligaments. And interspinous ligament he considered to be the main spinal stabilizing structure posteriorly. And 1963 Holsworth classification came out. He gave the concept of two columns. So there's the column just anterior to the neural elements. There's the vertebral body. That's the anterior column, and the area with the neural elements and the posterior elements. There's the posterior. So these are the two columns. So it expanded the Nichols system to the entire spine from thoracolumbar also to the cervical, etc. areas. There was first given the concept of burst fracture and gave the concept of stable versus unstable burst fracture. So in 1968, Kelly and Whiteside, they had a paper at the 11 cases, and they found these are all burst fractures, and they found that the burst fractures were inherently unstable. So this became basis for the Dennis and McCarthy classification. So this previous classification, Wöhler classification, Watson-Jones classification, Holsworth classification, Nichols classification, Kelly and Whiteside's classification, all have got disadvantages. One is that they are descriptive, anatomical. It's not indicative of management option or outcome. It was not validated because validation at that time was not considered important. And there was poor inter-observer reliability. So in 1983, Dennis came up with three columns. So Dennis was a French orthopedic spine surgeon. He was a disciple of Roy Camille, and he emigrated from France to Canada. And then Roy Camille actually founded the importance of the neural arch, where the neural elements remain. So he expanded it into three columns. So he saw 412 patients with thoracolumbar injury, with which there were 53 images of CAT scan. CAT scan was just starting to be used widely at that time, early 80s. So around from 76 when it was first invented. So there was 53 cases. And with CAT scan, so they divided the three columns. They divided into compression fractures, which is the anterior column, the burst fracture, which is the anterior and medial column, the flexion distraction, this is the medial and posterior column, and fracture dislocation. And this was the French Decollets and Renault. They emphasized on the middle column. So Dennis showed that even two column injuries can be managed conservatively. Those were stable burst fractures. But they found that there was poor inter-rater reliability. There was no predictive outcome. And McAfee in 1983, he again emphasized on the posterior ligamentous complex. And this was based on the biomechanical studies of White and Punjabi and those of Dennis. And he differentiated between chance fracture, that was bony, and other flexion distraction injury, which were pure ligamentous involvement. So bony chance had a better outcome than the pure ligamentous ones. This was not validated, not tested for reliability. Then came in 1984 Ferguson and Allen. So they refuted the column concept. Rather, they worked on the mechanism and pattern of injury. It was more mechanical classification. So they tried to go back from the type of morphology of the injury to the mechanism of injury and how the fracture occurred, which column failed first, then second. That way, it was not validated. It was complex, and there's a lot of subgroupings, etc. And it's not predictive outcome, and mainly because there's no talk of neurological injury. The spinal fractures, the most important thing is the neurology. Then came the McCormack and Gaines class in 1994. It was in, I think, 17 patients they did the study. So basically, by 1994, the pedicle screw system was being used, and it was for the pedicle screw fixation. What are the cases you go only posterior pedicle screw fixation, and what are the cases you have to supplement anterior? So that greater than 7 score had a high risk of failure in short segment fixation, and so we need to supplement anteriorly. So it was validated by inter and intra-observer reliability by Dye and Zinn. So again, there's one of the drawbacks of this type of mechanistic classification, this type of morphological classification. There's no consideration for neurological status and ligamental stability. Leventus injury or neurological damage is not incorporated and hence cannot be used to as a surgical indication. It was not validated properly as per the. So came in the AO classification, they reviewed 1445 Thoracolumbar classification. So they hold on to the two-column theory of Holsworth. Type A consists of compression fracture, type B with distraction fracture, type C refers to rotationally unstable injuries or those with multi-direction instability. So as you go ascend from A, B, C, the morphology of the fracture changes from simple to more complex type of injuries, more destructive type of injuries. So there it came in the current AO classification. So this AO classification, there's some changes like the earlier B3 was in type C in the Magal classification. So now they have unified it. And this is the first the morphology part, you have neurology part, then you have certain other modifiers like presence of any medical comorbidities, etc. So you can go from the more severe injury to the simple injury, or you can go this way. So the reverse, the more severe injury to the least injury is much more easier. So if you start, if you see a fracture, if there's in the X-ray there's displacement or dislocation, then it is a translation type of injury, so it becomes a C type of injury. And if there's no dislocation or displacement, then we go next and check for the tension band. If there is tension band injury, then it falls into the B subcategory. And in the tension band injury, if there is anterior tension band failure, it is a B3. If there is a posterior tension band failure, and if it is an osteoligamentous disruption, it is B2. If it is monosegmental osseous disruption, it is B1. So you see osseous disruption is much better managed than a ligamentous disruption. And if there is no tension band injury, there's only vertebral body fracture. You see, if there's vertebral body fracture, yes, then we have to see if there's posterior wall involvement. If there's posterior wall involvement, then we have to see if both the emblems are involved. If both the emblems are involved, then this is a complete burst A4. If it is not, it is A3 incomplete burst. If the posterior wall is not involved, then it goes into both. And if both emblems are involved, then it's A2 pincer split fracture or A1 wedge impaction fracture. If there is no vertebral body but any appendage fracture, it comes into A0, and there's no injury, so you can consider it to be no injury. So the limitations, they tried to fit all the fracture types into this complex, confusing classification. And initially there was no neurology. Later on, the current classification, they have neurology. There's little correlation because slowly the magnet MRI became more common. So there's little correlation between magnet MRI of instability based on posterior ligamentous injury and the classification. So came in the Tillich's classification, though a very simplified classification, it helps us. There is a lot of criticism to this classification there, but what they did is, they divided into morphology type, the neurological involvement, the posterior ligamentous complex, and they get scoring. So if you have morphology, there is a compression fracture, the score was 1. If there's a burst fracture, the score was still 1. If there's translation or rotational injury, the score was 3. If there's a distraction injury, so distraction indicates more severe type of damage, and that requires operation, it will be score 4. If there's neurological involvement intact, score will be 0. So there's no hurry to rush into surgery. If there's a nerve root injury, there's 2, because if you can decompress the nerve root, they can immediately be in function, and so it's more an indication for surgery. If there's a cord or conus medullaris, and if it is complete, it's 2, and if it's incomplete, it is 3. So those are incomplete and in critical areas, they will score more. If there's a chorda equina critical, they score 3. That's more. You need to go for surgery. If the posterior ligamentous complex is intact, it is 0. If this injury is suspect or indeterminate, because 2, because sometimes it is difficult to gain an idea, because you cannot do an MRI, you cannot, the patient might be moribund, so you cannot turn over and check for tenderness. And if it is injury, definitely, so it scores 3. So we add up the total scores, and if it's less than 3, generally it's non-operative. 4, it's a borderline, you can go operative, non-operative, look for any other modifiers like neurology and chest injury, etc. And if it's greater than 4, go for operative. So this gives us a rough idea of surgical plan, like if the neurological status is intact and the posterior ligamentous complex is intact, go for posterior disrupted, go for posterior root injury, posterior. Basically, if there's an incomplete spinal cord injury or chorda equina, and if the posterior ligamentous complex is intact, you have to go for anterior or disrupted, go for this is similar. The limitation is that MRI is required to identify the posterior ligamentous complex, though CT scan can sometimes the splaying of the spinous process can give us an idea. Clinical examination can also give us an idea, but MRI is sometimes not always possible. And a PLC score of 2, that is indeterminate, can tell decisions here and there. So, rotation injury score of 3, non-operative answer. So it's very rare that you can have a rotation injury of 3 and have no neurological injury, but you could have very rare outliers. And methodology is a bit unsubstantiated. Validity and ability to predict outcome is unproven. And validity studies was performed by spinal trauma study groups. To summarize, there's strengths and limitations of this classification. So best is to use TILIX along with the current IOA classification. And there should be, though it's a good type of what to do, what not to, but you have to keep your eyes open, see if there are any other injuries like facet disruption, displaced horizontal, displaced horizontal fracture of lamina, they are involved with more neurological deficits. If there's vertebral body commission for more than 75%, if there's increased transpedicular distance, if there's spinal canal narrowing, doubtful posterior ligamentous complex injury, and always you should add an clinical section. And there are other things like the multiple fractures, if there's a polytrauma patient. So you can vary your decisions. But this is this TILIX classroom gives you a basic idea. And I will surely thank Dr. Tikoo for inviting me, and also for the West Zone for inviting me. Much of his slides is from me. And thank you.
Thank you, Dr. Jaydeep. Thank you very much for this excellent talk. So that has set the base for the next talk, which will be by Sanjay Dhar sir about the classification, the management based on these classifications, and does it really help in management of the patients. Over to you, Dhar sir. We'll take the questions at the end of the lectures.
Thank you, Agnivesh. Thank you, Dr. Dhiraj. Thank you, Dr. Shinde, for allowing me this opportunity to speak on this thoracolumbar trauma. I'll be talking about the various classifications and how we can sort of use them this on a sort of an algorithm manner in the management. I am Dr. Sanjay Dhar. I am from Navi Mumbai, D.Y. Patil Medical College and Apollo Hospital. If you can see this on your screen, this is a young patient who has some neurodeficit. He has a burst fracture of L1. And if you can, he has, as is evident from the chart, you can see the deficit. Anal tone is weak, perineal sensations are diminished. So you can see, as you look at it, you will definitely know that considering that the neurodeficit, as every neurodeficit patient almost falls in unstable category, purely because of the neurodeficit, because it has cause the instability and damage the cord, so that itself is a pointer towards instability. But if you see on the X-ray also, you can see there is anterior column is disrupted, posterior column is also partly disrupted. There is ballooning of posterior wall, but we don't know anything about the soft tissues behind. So if you classify, you can see the MRI, not very clear, any posterior injury, but you can see there's a burst with the posterior wall impinging on the cord. So there is a significant neural compression. So then, if we take CT, one point here is over the years, as I was trained, we thought of in trauma, we would only do CT because there was no role of MRI that time. Considering that there's an acute injury, you know the level, so MRI really doesn't make any more difference. But now it has been over a period of time, it has been seen that we have to sort of amalgamate all these radiological modalities to reach a consensus on the management of these injuries. So CT, MRI, X-rays, all of them, plus a thorough clinical examination, as Dr. Ghosh has also very clearly told you, is necessary to sort of classify them and then plan the management in these cases. So you can see there's a burst fracture, the L3 burst fracture with posterior wall disruption. So if you put it on the T-leaks, as Dr. Ghosh told you, you can see the burst fracture of L3. You can give it 2 points. T-leaks is based on morphology, integrity of the posterior soft tissues, as well as the neurological status. So the points are as per the compression, burst, translation, and intact suspected, although they are not very clear about the posterior PLC integrity on T-leaks, but it is the points are given like that. So if you put the same X-ray on this parameter, so you will see this almost 5 points. So 5 points luckily is very clear that if it is above 4, you have to go for surgical management. And if it is 0 to 3, it is non-surgical. So 4 is a very limited zone where you can think of sort of a surgeon choice. So if you put this in, it is a surgical case. So you see here, you can plan it. You have done it. We have done a surgery here in this case, decompression. And this patient has done well, luckily. So he improved, his urinary continence improved. He started walking. I don't know if the video will work. No, it will not work. So so luckily he improved. So, but putting this classification on the on test, so there are very little. The quality of evidence is very low. There is no you can see there's no specific. There is no surgeon sort of inter-observer reliability of this classification still. And the better agreement, as you can see, better agreement among surgeons around the world, better clinical trauma victims. The recommendation, the evidence is quality of evidence is very low and it is weak. So it has been seen that there's a very good paper by Joachim et al. That the patients with 5 or more points benefited really with this treatment, and there was improvement in majority of the patient in neurological status. But there are almost a very significant large percentage of patients, which is almost 5% of patients with score less than 4 patients who later required surgery because of progressive kyphosis pain. So these cases, if you really put them strictly on classification, probably would be missed, and so you would end up in a troublesome situation. So T-leaks, a poor reliability in injury, morphology description, imprecise description of the PLC complex status. There's not very clear clarity about the PLC complex in T-leaks classification. So burst fractures without deficits may require later surgical treatment for local kyphosis and pain. So this is the group which is somehow missed in this classification. So now then came the new AO, so the Vaccaro and his large group of surgeons who sort of modified the existing AO classification, OTA classification. And so they divided, as Dr. Ghosh told you, that compression injuries, distraction injuries, and translation injuries, or A, B, and C. And they added the neuro part into it, and classifying them as N0, N1, N2, N3, and 4. So it is a much more, morphologically is much more clearly described in this classification, as Dr. Ghosh again very clearly told you. So as you go from C to A, C is if there is displacement, so there is instability inherent with neurodeficit, so it is very clear. So then if there is only posterior elements, again, posterior element injuries are much more defined, but as compared to T-leaks, but again, still there is still areas where we can sort of be wanting in the management plan. So similarly, morphology is much more well-defined, like insignificant wedge impression, split pincer type injuries, or incomplete burst fractures and complete burst fractures. So but still, although AOS classification had better reliability for identifying fracture morphology as compared to T-leaks, for neurological status, near perfect intra, everybody agreed, as I told you, on the neuro part. So if there is a neuro deficit, everybody would agree on this. But if there is the morphological injuries and PLC injuries were not very well defined, so there was little inter-observer variability in such cases. So if you can compare them, correct terminology, T-leaks is not very clear, although AO gives you much better terminology. Morphology diagnosis, AO is much better. PLC injuries, AO is much more clear. Burst fracture determination, again, AO is much better. Assessment of severity is much more clear. So these are the points on which AO definitely scores, but ease of use is little complex. So it is very difficult to sort of remember the classification. So again, in the areas of weakness in this case. So coming finally to spinal stability, the legendary definition still remains true, White and Punjabi. The ability of the spine to maintain under physiological loads relationships between the vertebrae such that there is neither damage, spinal cord nor the nerve root. So it still remains true, and most of the surgeons ultimately end up using their own understanding of these injuries to manage such injuries. So injury classification, there are some certain good papers who have come out like to finally sort of simplify it all into three zones, like stable injuries, potentially unstable delayed instability, where there can be delayed instability, and clearly unstable injury. So we agree on stable and unstable. So it is this mid zone where we probably would be sort of between surgeon will be sort of confused in a bit. So stable injuries, as I told you, everybody is clear. It is minor fracture, transverse, mild canal compromises, which all improve over a period. AO types, 0, 1, 2 subtypes with neurologically intact patients. So these are, as I told you, stable injuries, something like this, where you can see there is a single end plate involvement, and then slowly they heal and without any major kyphosis, and they do well in such cases with conservative management. So then coming to the mid group, which I told you is the most confusing group, where there is potentially unstable injuries. These are burst fractures with moderate or severe canal compression, more than 50%. Then there may be combination, mild radicular symptoms may be present. They are not having very clear neurological deficit. And in the setting of severe worsening, so whenever they sort of go into worsening pain or progressive deformity or incapacity to walk, then you will need to convert yourself and get them on this OT table. So you probably need to operate on them. So primarily they may be in a stable zone, but over a period of time, they may go into the unstable zone and they may need surgery. So something where I told you, you need to use all the modalities. Like as I told you, as I got trained, I was very clear that I need to do only X-ray and CT scan. But now MRI has become a very important modality in such cases to identify the posterior injury, posterior soft tissue injuries. So if this is this, then it becomes an unstable injury. So all this, it becomes in the zone of potentially unstable, which you may miss on X-ray, which you may miss on CT scan, where you need to do MRI. So non-operative treatment in such cases may not be a good option. So over a period of time, they will go into kyphosis and they will have painful kyphosis. And once you operate on them later, they might need a very much larger surgery, like an anterior posterior, like we have a large defect here, you have to put a graft anteriorly, or we can put a cage there from the back or front, two-stage or single stage. So they become little delayed surgeries where you need to do a much more morbid procedures. So initially, if they can be managed with indirect compression, they may get good restoration of the height, good canal or improvement. The canal automatically gets decompressed over a period of time. You can see here, it doesn't need to be really punch the fragment in. So this is another example. Now, if you can see this, this is 1 year post-injury. You can see on MRI, there are still signal changes persisting on MRI after 1 year. So that means it is an unstable situation, as that is why they are painful. So you can see the lysis occurring and collapse, progressive collapse occurring even after 1 year. So probably conserved initially, and now they have come lately for their pain and progressive kyphosis. So such injuries need to be identified primarily at the beginning by putting a better classification system. So probably not a single classification. So you have to use all your knowledge to use. And then, so again, this case where it was a delayed surgery for 1 year, we have done posterior column stabilization, posterior stabilization. We tried to get some restoration of the anterior column or the middle column by putting a pedicular cage into them so that there is some restoration of the anterior height. So again, this is these are potentially unstable injuries where you need to sort of identify them early by combined use of all the three. So no classification may sort of fit into one category where they call you can operate, but you might have to use both the classifications, or you may have to use your own clinical skills, or the merging of all the radiological modalities so that you reach a conclusion for it. So these are this is one example of a clearly unstable injuries where you have a pincer type fracture, complete burst, posterior the whole posterior wall is intruding into the canal, you can see. And so they are very clear. So as I told you, if there is neurological deficit, it automatically qualifies itself for an unstable injury. So you need to put them into clearly unstable injuries where you need to operate. So again, an 18-year-old boy who had this injury with neurodeficit, bowel bladder affected. So clearly a cauda equina, which gets high marks in all the in AO classification as well, where you need to do early surgery. So MRI shows burst fracture, cauda equina injury, and then you can see the posterior column. So they need to be operated. So based on TALIX, it gets 5 points. So it is very clear here, 3 + 2 + 5. So everything is very clear. So even by AO classification, as I told you, if there is neural injury and there is burst, so they get very high marks, and so they need qualify for automatically for the surgery. So that's why I said it's not a single classification, which probably will help you. So you need to be aware. So these are the intraoperative where MIS was done. The fragment there was no need to push the fragment anteriorly because it automatically decompresses, and almost up to 80% of the canal compromise will improve with time once you restore the anterior column and the posterior column. So this is the post-op, good restoration, and patient has improved. He starts walking and getting a good result. So current treatment modalities can be, you have to identify the injury morphology, you have to see the neurological status, clinical status. So all this has to be amalgamated into one. And then finally, the multimodal radiological evaluation, which I told you. So it is not a single classification which value defined. So don't be dependent on one single classification. So use all these modalities, including the radiology, to reach a conclusion so far as managing these injuries concerned. So acute thoracolumbar injuries, stable injuries, potentially unstable and unstable injuries. So neurological intact, minor fractures, they go to non-operative. So if there is any neurological intact, but there is fractures which are unclear definition, single plate burst or a canal compression. So non-operative maybe, but they need to be observed progressively. So if there is any refractory pain, they go to the operative management. Similarly, unstable are very clear. So this is the all amalgamated into one, and that actually defines how you manage these surgeons. So just at the end, this is the last example where you had uh, two fractures. You can see single burst and this. So together they all they may be isolated, they may be classified into non-operative management, but if you put them all together, both together, so you score very high points. So it needs a surgical management. So this is uh, uh, well defined. And in the end, I would again say that all the modalities, radiological as well as classification, should be used and you to your benefit to give the best benefit to the patient. Thank you very much.
Thank you very much, Dhar sir. So that makes the classification based treatment quite clear. The limitations are very well defined now. So I will proceed with the third talk, which is basically tips and tricks in osteoporotic fracture. Dhar sir, I would request you to unshare your screen.
Yeah.
We'll take the questions at the end. So basically how osteoporotic fracture surgery is different than conventional surgery. That is the aim of this talk. Is my screen visible?
Yes,
Yeah,
yes.
Okay. So basically we tend to put more screws in an osteoporotic spine to get better purchase. We tend to medialize them more so that we can get better hold. Hydroxyapatite coated screws have been described and are available in the market. We cement augment normal screws, or we have cannulated screws which help us to augment the fixation. We try to aim for a bicortical purchase, and we use laminar hooks, sublaminar wires, tapes, and all to augment the hold of a pedicle screw. So the contact of the screw is most important with the bone. So you try to put the largest diameter screw, which can be safely put in the pedicle, because that will give you a better hold. There are conical screws which are described, but the problem with conical screws is that you get good insertional torque. That is, when you tighten the screw, you feel very well. But as soon as it loosens, it will pull out immediately because it's a cone which has been sort of impacted into the bone. It does not have any thread-based purchase. So we try to aim for the opposite cortex because it gives us around 120 to 150% more strength than a screw, which is 80% of the length from the pedicle to the anterior cortex, which is the normally length of the screw. We try to put more straight screws in thoracic spine because they have a 27% better purchase and pull out strength as compared to the anatomical screws, which would go down into the vertebral body. We usually try to avoid tapping, but if it is required, then we should under tap it by 1 mm, which is the standard convention. And cement injection does increase the screw pull-out strength. So if you medialize the screw more, like 30 degrees as compared to straighter screws, you get 28% better purchase. And if you pull out a screw, the better is to replace it with a larger diameter screw, or cement augment that hole and then put preferably a 1 mm larger diameter screw, and it will hold on well. So if you revise a 6 mm screw and put a 7 mm screw, it will have 73% better purchase. But if you cement augment the same 1 mm screw, sort of oversized screw, then you get a significantly better purchase, which is 384%. So this is a case example of a lady who had 2-level osteoporotic fractures and have been treated by vertebroplasty and cement augmented fixation. She went to do very well. Cage plasty is something, an intra-body vertebral cage reconstruction. So you put the vertebral cage inside the vertebral body that jacks open the vertebral space and provides an instant anterior column resection, which is easily amenable. You don't need to take out the discs above and below. If your end plates are intact, you can safely do this procedure. And this is the 1-year follow-up where the fracture has consolidated well. We tend to use dual thread screws because they provide better pull-out strength than the conventional one. So this is a case example where dual thread screws along with the cage plasty or intravertebral cage augmentation has been used. Sometimes the end plate is destroyed, and in that case, the disc also needs to be taken down. So in that case, we put the cage in between the inferior end plate and the sort of superior part of the vertebral body minus the end plate. The problem with screws and all is that the screws offer 3-column fixation, but in sort of patients who have very less bone density, they may not provide any sort of fixation. So rather than there was a classification system which was followed in old time based on X-rays, wherein it was said that it is better not to put screws if your hydroxyapatite concentration is less than 100 milligram per ml. And in this, in grade 3 osteoporosis, it was only poor fixation. You could not achieve any good fixation. And in bone density, if your absolute value of BMD is less than 3 grams per centimeter square, it is recommended not to do pedicle screw fixation. And this is what happens if you put it. The screw will slowly tend to back out. And in a situation where surgeon then stands naked in front of the patient in an unpleasant situation where an elderly person is in pain, the ultimate rescuer which comes is the heart shield. So this you revise with heart shield and it allows a controlled collapse. It has a hold in the lamina, which is much better. And this article studied 3 different types of sublaminar wires, or what we sort of call as wire, tape, and hook construct. So with respect to laminar cut through test and stiffness of construct. So tape or braided cable was better than wire because they have a wider base and they tend to sort of cut off less, but there was no difference in the stiffness of construct. So to conclude, understand the stability pattern and treat accordingly. If the instability is intravertebral, augment the vertebral body. If it is intervertebral, then you need to reconstruct anteriorly, take out the end plate and reconstruct. Keep multiple options available with you, including cements, dual thread screws, heart shield, also in these cases, and have a customized approach towards each patient. Heart shield is the ultimate rescuer, and most important is do not miss on treating osteoporosis, because if you don't treat osteoporosis, any fixation will fail. Thank you so much. So with this, I would request the next speaker, who is Dr. Pritam Majumdar, to give his talk on spinal cord injuries. Dr. Pritam, are you there with us?
Yeah, good evening. Good evening, all the faculties. Thank you for this invitation. Let me share my screen. Is it visible to everyone?
Yes, it is visible.
Okay, thank you. Yeah. I'm a neuromodulation specialist. I'm a neurologist. So I do work in Delhi. It's my center, Neuraxis Care and Research Center. I'm the director and chief for Department of Neuromodulation. And for spinal cord injury patients, what we do epidural stimulation. We started doing it, it's been last 3 years. So I got trained in USA when I was there for my fellowship. So me and Dr. Susan Harkema, we used to work together on this epidural stimulation on Kentucky Spinal Cord Research Institute. And after that, I started using this epidural stimulation in Germany, in my center, University of Cologne. I'm a visiting professor over there. And last 2 years, I started doing it in India. So in India, it's been 50 cases we have done so far in last 2 years with the spinal cord injury patients. So we give this option to the patient who has complete spinal cord injury, and sometimes we do patient with incomplete spinal cord injury. Also depends on patient's visibility of the spinal level where they have the injuries. So this is small basic introduction about this epidural stimulation. So we take patients in two different ways with a
Dr.
Asia
Pritam,
A.
we are not able to see your slides.
You are not able to see my
Yeah.
slides.
And your voice is also coming a bit, there is a lot of static noise in your voice. I'm not sure if you're using headphones or something which is. Can you reshare your screen, please?
1 minute. Is it visible now?
Yeah, please reshare it. Please reshare the screen.
Now is it visible?
Yeah, it is visible now. Now make it full screen.
Is it visible now or it's not yet?
No, not yet. No, it just goes away. So maybe you can go ahead with the, don't make it full screen and just go ahead with the previous one. Yeah, the one which you were doing out of full screen. Yeah.
Is it okay?
Yeah, this is still visible. Yeah.
Okay, fine. So introduction, we just give a small introduction about epidural stimulations. So we take two different types of patients with a complete spinal cord injury and also the incomplete spinal cord injury. So we mainly like to work with Asia A, those who are complete spinal cord injury. And it's mainly T5 to T12 in the level of injuries we take. And high cervical injuries, like especially from C2 to T4, we have seen the patient's improvement. It gets very delayed because of the high cervical region involvement. And in epidural stimulations, our main focus is to get back the patient's motor control of the lower limbs, especially the stepping and the standing pattern to generate with the combinations of neuro rehab locomotion training program. And we have seen the patient with epidural stimulations improved the motor functionality as well as the sensory functionality also. The motor functionality, we have seen patient improved up to 60 to 70%, and the sensory improvement around 35 to 40%. So there is three hypotheses what Dr. Isdorfer discussed in 2020 in his paper. So the first hypothesis, we usually work for the epidural stimulation. It's basically strengthening the monosynaptic connections between the proprioceptions of the efferents and the motor neurons. So our epidural electrical stimulations, we usually worked on this because the way we put the electrodes on the spinal, so just for the strengthening of the monosynaptic connections between the proprioceptions, basically we are working on the neuroplasticity. The second hypothesis, that is a reorganizations of the propineal spinal circuitry around the listening site. So for this, we tried before the nerve grafting and all those, but unfortunately it didn't work, but we tried on that also with the peripheral nerve grafting and peripheral nerve stimulations process like a brachial plexus. So we used to have different peripheral nerve stimulations for this spinal cord injury, but we didn't see the good responses on that. And the third hypothesis is a spatiotemporal integrations of the internal model with the peripheral afferent inputs. So this hypothesis is working by Professor Kutin in Sweden in his lab. So he has developed some other new devices which can be integrated with the sensory, like when the leg is going to touch to the field or to the ground, it automatically will activate to the sensory motors. With this, that is going to help to the patients to have the motor power like standing and the stepping. This thing is still under the clinical trial is going on. It's not yet tried clinically in other centers. So we usually choose patients like how we choose patients. So when patients come to us, we usually see patients that what kind of injury patient has and how many years of injury. So we usually try to take the post-injury 9 months, because we usually wait for 9 months to just to see that spinal shock should not be there. Some patients, they can also have spinal shock post 9 months also, up to 12 months, like up to 1 year. But if patient has complete spinal cord injury, like especially if it is Asia A in T5 to T11, we usually wait for 6 to 7 months to do the epidural stimulations, because we need to see is there any spasticity or not. If it is a higher level, like from the C3 to T4, we usually wait for 9 months just to find out how much improvement patient is getting on the upper side and also the lower side. And apart from that, we have the muscle testing, because we usually see after spinal cord injury, immediately patient comes to wait for 6 months to 7 months to see how much muscles, the responsive muscles are there, how much muscle wasting is getting, what are the spasticity level. And also we do the whiskey scaling, like it's from the standing to scale, that how much patient is able to stand with support, how much patient is able to feel the sensory part from all those. And when it comes about the spasticity, in spasticity, we usually see the scaling like from 0 to 5. And usually the patient who has T5 to T11 spinal cord injury, their spasticity usually up to 3 to 4. The higher cervical, the higher level of injuries, spasticity is around 2 to 3, we have seen for the lower limbs. So what are the surgical details like for the epidural stimulation? So first what we do one MRI scan, because our area of interest is the conus region. So it can be injury in T5, T6 also, it can be injury in T10 and T11 also, but our electrodes, our place of interest to put it into the conus region, which usually depends on to the T11 to L1 in between. So we usually do first when patient comes, we do the patient's MRI scanning to find out where is the conus region. And once we get the conus region, we don't do minimally invasive, we do the open laminectomy. We completely open T11 to the L1 area. We put our trial leads and then we stimulate. And after stimulations, we see that how much muscles are responding, which are the muscles are responding. And then we combine with this to the EMG to find out how much muscles usually responding, because we have 50% cutoff. Like if muscles are not responding more than 60 to 70% in our EMG, so we usually don't put the electrodes. So this is just one picture of the surgery when we do. So how we do open laminectomy. So we find out the conus region. It comes to the T11 to L1. And after putting this T11 to L1, we need to adjust, depends on the muscles responsive. Like sometimes we have seen the electrodes we need to put from the T11 base to the T12. Sometimes we put T11 lower base to the complete T12, sometimes half in between, like T11 half and T12 half, depends on how the muscles are responding. On the on-table stimulation, like this patient, what I'm showing, this patient has an injury onto the D10 and D9 and D10, and we have done epidural stimulations 1 year before. In 2021, we have done the surgery. Intraoperative monitoring, when we do so, we usually see the 4 muscles. We have our targeted 4 muscles. So one is in the rectus femoris. We need to see how much it is, getting the signal. Second, we see the hamstring. Third one is the tibialis anterior, and the fourth is the most important, is to the maximus, the gluteus maximus. Depends on these 4 muscles responses, we decide this patient will be improved with the stimulations or not. With the patient will be able to work with assisted work, like with a worker, or not, depends on these 4 muscles responses. And this is just one example, like when we stimulate on table, what we usually see. So these are the graphs of the EMG with the stimulations. So we do on stimulation, off stimulation, once again on and off, and we the place of the interest, we decide depending on the stimulations how the patterns are coming. The post-operative EES and the muscle electrography. So the most important after that, the programming of the device to getting the complete current, the amplitude to adjust according to the patient's stepping pattern. So post-surgery, next day itself, patients can able to move their legs, the both leg, the bilateral, and after 5 or 6 days rest, we usually start the programming of the device. So it usually take 45 days, 40 to 45 days to make the patients able to stand and get the stepping pattern and work with the worker. In 45 days, patient usually, they go through with a advanced neuro rehab with the programming. And in that programming, we use 0.1 volt up to 10 volt. And sometimes we go beyond 10 volt, depends on the patient's the stepping patterns. And the frequencies we use 5 hertz to 60 hertz. So 5 hertz is basically we use for the spasticity to reduction. And the 60 hertz, the higher amplitude, we use like higher frequencies to getting the stepping pattern. And so, and the third is in the pulse width. Pulse width depends on the areas, like how strong we want to give the current for the patients to sustainability of the stepping patterns. So that comes after the surgery. Like after 1 week, we usually get back to the complete program patterns with this to make the patients work. And what are the results? So we do started scaling. So we do pre and the post-op scaling. Like first we do the lower extremity motor scaling. So here I'm showing around 5 patients databases, the last 1 year, the patients who has undergone treatment in our center. So the first, before the epidural stimulation, the lower extremity motor scaling, it was 0. And after 8 weeks, it came back around 18. The mean square, what we got it is an 18.1. The light touch sensory score, which was before the participants, it's around 48. The mean square was in 48. After the 8 weeks, that became around 56. So it proves that the sensory also started improving post 8 weeks, means post 2 months. Pinprick sensory scores also, it was before in the mean in the 52, and that increased to 73. And the best score what we got, it's 76 out of 112. Then we go with the modified Ashworth the scale. This is for the spasticity, because we have seen the grade 3 spasticity usually comes with this the lower spinal cord injury, less than T5 to T11 or T12 in between. So the highest we got it around grade 3, and the post stimulations of the 8 week, we have seen the patient's grade came down to 2, and then after 3 months it's 1, and now after 6 months patient almost it's nil, like there is no spasticity because of the stimulation. And this stimulation for the spasticity, patient needs to use all the time. It is not only just for 1 hour or 2 hours. It's when patient is not using the current for working, they usually switch back to the current for the spasticity, and it works 24/7. Here are some programming patterns, like how the epidural electrodes when we put, so how you do programming combination. So there are 1,000 multiple ways, combinations, permutations available for doing this programming, and each patient is different. Each patient programming pattern is different. Each patient's frequency to pulse width to amplitude is different. So here I'm just showing that we have our first participant. So in the first participant, like we do programming in a supine position, then in the sitting, then in standing, and then in the stepping. So the usually patients have 3 to 4 different programs, like in a lying condition, how they want to move their legs for this one program, in a sitting if they want to move their legs for another program, and the standing and the stepping. So there are the 4 different programs we set for the each patient. And each patients usually have a different contacts of activation, different contacts of the preservations for the proprioceptions activity. Working index for spinal cord injury patient, like Whiskey score. Here we're showing the patients, the first participants who are not, could able to not even to take steps. So after that, when the post 8 weeks, we started seeing this patient improve 50%. And after 12 weeks, the patients start improving more. Like, so we usually we have seen our best score. The patients started using the worker, started working around 500 to 600 meter post 8 weeks. And after that, patient, after around 12 weeks to 16 weeks, patient started working approximately 700 to 800 meter with the walker without any other support. This is one another scale for the sensory. This is for the bowel movements. So we have seen the patients usually improve the bowel. The bladder, it takes time to improve, but the bowel systems, we have seen the patients started improving. They started feeling about it, that they need to pass the bowel. The bowel sensory part improved up to 35% for our patients. And the bladder, it's improved around 15%. But for the bladder, we do sacral nerve stimulation. That is another different nerve stimulations for improving the bowel, the bladder system, the control and the sensory part. So I'll just conclude this talk. So EES is a potentially, like epidural electrical stimulations, is a really potential effective therapy for enhance the sensory motor recovery, especially following patients with a spinal cord injury, because this is the most advanced therapy what we have so far to give patients after spinal cord injury. Because spinal cord injury patients, they have no other options, because if we go only for neuro rehab, so now in neuro rehab, they have launched Cyberdyne, they have other robotic assisted therapies. But if you see for the long term, it is not the solution for them to give one for the long term the improvement. For incomplete spinal cord injury, those who have less than T10 and T11, after some time with orthostasis or something, they're able to walk. But for the complete spinal cord injury, for them it's most important the body balance to improve the sensory and all those, which orthosis or the robotic neurorehabilitation, it is not sufficient to improve that. So far, this epidural electrical stimulation is one of the most advanced which we have seen for patients' improvement in the motor as well as the sensory part. But still, epidural stimulations needs more analysis in multi-centers, because now it's only few centers across the globe we are doing it, not the many centers. The most important thing in this epidural stimulation, the first, the proper lead placement, and the second, the programming part, because the programming is the most challenging, most time-taking, and the most devastating in this state. Because if we cannot do program proper way, patient will not able to have any single movement on the legs. And the third, what we need to do, the third part is to combine this electrical stimulations with the neuro rehab, like with the proper physiotherapy sessions. And also the patient needs to understand that how do they have to make their trunk balance, their body balance, and the food, like the diet and everything. And I will show you some videos of our cases. Those who
Dr. Pritam, so sorry to disturb you. Just in interest of time, I'll request you to quickly go through.
Yeah, so I'll just like to show the videos. I hope this will play. Let's see. Some issues here. So how we pre and post, how we operate it, and then how we take care of the patients. And it usually takes 45 days to 6 days in our center. Patient who stays for the rehab with the programming and then assisted working. And one more. I think we have some time. Sorry. Thank you. So
Yeah,
I
thank
will
you,
finish.
Dr. Yeah,
Yeah,
thank
I
you,
will
Dr.
finish the
Pritam.
presentation in that. Yeah, thank you.
Thank you. Yeah. So we'll quickly discuss one case. Dr. Pallav, are you ready with the case? Any questions to the faculty? Dr. Jaydeep's talk, Dharsar's talk. Any questions? Dr. Pritam's talk from anyone? Yeah, Dr. Pallav, you ready with your case?
Just a minute. Yeah, just a minute.
Yeah.
Yeah, so can you see my screen?
No, you have not shared it yet. You need to share your screen. Just click the green.
Yeah. Sure. Yeah. So this is a female patient, age 25 years. She had a history of fall, and as we see that she has developed burst fracture of L2 vertebra. She was having bilateral lower limb grade power 1/5. Her sensations were intact, and bladder ball was involved. So yes, so this is her MRI. You can see that there is good amount of cord compression, and and these are the axial views. So how to go about with this case? So what you will do, Dr. Agnivesh?
Yeah, it's a bad injury. So it's a complete burst fracture of L2 with a significant retropulsion into the canal. The discs seem to be intact, but do we have a CT scan here of this patient?
Yeah, I don't have it right now. Actually, I was just told in the afternoon. So,
yeah. So was the upper end plate intact in this patient, or how was it? And the
yeah, it was no, it was damaged.
It was
upper end plate. No, upper end plate was not upper end plate of the fractured vertebra was damaged.
Yeah. So basically, this needs a reconstruction. And you said patient has bowel bladder, and it's a complete injury or an incomplete injury?
Incomplete.
Incomplete injury. So this patient will require a surgery. So ideally, it has to be a anterior surgery plus posterior augmentation, if you ask me. But we need to remove the compression in the canal and then reconstruct the anterior column, which is there. The CT scan will help us to understand whether we can reconstruct it from posterior or we need to go anterior. But definitely the vertebral body needs reconstruction, and it needs a short segment. We'll try to keep it as short as we can because she's a young female.
Yeah.
And we'll try to preserve the lumbar mobile levels as much as we can.
Yeah. So how many levels up and how many levels below?
No, in this case, the patient is 32 years, you said?
Yeah, 27.
27. So
Hmm.
I would tend to fix it in a way that I'm not crossing, means I'm just doing one level up and one level down. Because if you reconstruct anteriorly, then you will not need more than one level in this patient. If you don't reconstruct, then you need to go longer. So my aim would be to reconstruct and keep the segmentation shorter, like one up, one down, and maybe index screws also, but with an anterior reconstruction.
Okay, and anterior reconstruction you will do with the with what? Like, would you do a bone graft, or you will do a mesh cage, or you will just push a graft? What you will do?
No, in this case, that's what I said. CT helps us to understand what we can do from behind or front. But if it is completely comminuted, broken, then it is better to go anterior. It's a clean retroperitoneal approach. You can remove both the discs and put a good mesh graft, good size mesh cage with bone graft into it and span it from L1 to L3.
Okay. Why won't you do it from posterior?
No, there's no no hindrance from posterior. If it can be done from posterior based on a CT scan and all the imaging, then I will attempt to do it from posterior. But you can't span the whole sort of a mesh, the vertebral level from L1 to L3 without doing an expandable cage, because the roots are there, so they come in your way of putting in the cages and all.
Right.
So that is the reason that I'm thinking of going anterior. Maybe Dhar sir can add to this.
No, this is an unstable injuries, as Agni said. It needs something front and back. Try to conserve the segments as much as possible. If I'm not sure if the X-ray is there, I can see the inferior end plate is still there. So if you can save the L3, L2, 3 disc, I think, great. From the back, doing anterior would be very tough. Otherwise, you'll have to do two above, which makes the whole segment fuse. So I'm a very big fan of short segment. So I would do one above, one below, and then see if I can restore good height. Then consider anterior. Anterior, if you, as I told you, if you can preserve the inferior end plate, which probably a CT would make it more well defined, then I will span it from the inferior end plate of L1 to L2 inferior end plate. So you can use anything. You can use cage. These days we only use cages, but I have used iliac crest grafts also there very nicely, and they do well. In younger patients, in fact, you are very safe if you put a good tricortical graft there. You sort of forget about it. There are no cage related complications.
Yeah. So this is what I did. So I went all from posterior, and I put a expandable cage and reconstructed from posterior only. Any comments?
No, it looks good. Yeah.
Agni, carry on.
No. Please, sir. Go ahead, sir.
No, it's a good reconstruction, excellently done. Although I feel it is very tough to put such a large cage at L1, 2. You need to handle the roots very meticulously, and then to turn the whole cage and get it into that much position you are a brave surgeon.
This patient improved in almost 3 months. So 3 months she was totally almost 4/5, like walking.
Yeah, looks quite good. Looks quite good. Good. Dr. Jaydeep is there. Dr. Jaydeep Ghosh.
I am there.
Yeah. Dr. Jaydeep, any thoughts, any comments from your side? What would you do anything different than this?
Actually, I don't do much of anterior. So constraints in my place. I was trained to do so. I would rather go 2 up, 2 down, and span a long segment. You can criticize me, but in my hand that works. And as to at the index level if possible.
Right. So I think, Pallav, this was excellent. this was a very bravely done, very excellent reconstruction, and the patient is also recovering well. So we are happy about it. So we had only one case, right? Am I right?
Yeah, actually, I
Yeah.
was.
Yes. Because of time constraint, we had kept only one. So thank you, Pallav. And I would also, on behalf of Western IOA, on behalf of the organizing and the sort of the organizing team of this webinar, I would like to thank the faculty, Dr. Sanjay Dhar sir, Dr. Deep Ghosh, who joined us from all the way from Guwahati, taking out time on a Sunday. And thank you, Dr. Pritam, for that excellent lecture on neuromodulation. And thank you, Pallav, for that excellent case.
Thank you.
Any comments from the faculty?
No, it's I think.
Right. So in that case, we'll call the session to an end, and have a very good evening and enjoy the rest of the evening. Thank you so much. Thank you, Dhar sir.
Thank you very much. Thank you.
Thank you.
Thank you.
Thank you very much.